now we are progressing with the final speaker, and that speaker is someone who is well known to be able to condense a very complicated subject with a very in a very easy and simple way, and to deliver that strong message. And that is Professor of Psychobiology, BERTHA Madras from Harvard University. And Bertha, she has been serving in the Opioid Commission, advising on what to do against the United States opioid epidemic. And she's happy to be here and talk about that. So, Bertha, you are always welcome. And you have been with us many times. We're honored to have you here. Would you like to have a yeah, applause? Would you like to have this? Oh, please, we'll do that. Yeah.
Thank you, Sven. Thank you. Can you hear me?
He's it on, so.
I'm so short that I need to get all the flowers. And so good morning, everyone. I'm delighted to be here and address such a vast array of international representatives from so many countries. My topic this morning is the opioid crisis, which in many ways is made in America, and hopefully it will fade in America. One of the reasons that I want to address you on this topic is to understand the origins of the opioid crisis in the United States, and also some of the solutions that we've generated as a result of the President's Commission. The opioid crisis: is Europe next? Is Sweden next? Is South America next? Is Africa next? The reason I say this is that there is some knowledge that the pharmaceutical industry is now targeting international companies, international nations, because there is such a pushback in the United States against them. The ancient Greeks had a term called pharmakon, which meant a poison as well as a medicine. And there is no better terminology for opioids than pharmakon, because in some ways it is the very finest reliever of pain, and in other ways it can produce agony, the agony of addiction, the agony of overdoses, the agony of death. Pain is the #1 reason, medical reason, why people choose abusable drugs. And one of the problems that we face is that the pain and pleasure centers in the brain are closely linked. So what I'm going to try to address very quickly this morning is the state of the opioid crisis, the root causes, the Commission report that I've just finished serving on, and some prevention strategies. In the United States, a vast number of preventable accidental deaths have been reduced markedly over the years. Since 1900, falls have declined. Fires, deaths due to fires have declined. Deaths due to poison has declined. Deaths due to drowning have declined dramatically. This is a chart from Steven Pinker's new book. The only deaths that haven't been reduced, in fact have increased dramatically, are deaths due to drugs. And that's the one area where we have to have a concerted effort to reverse. The United States leads the world in prescription opioids. It leads the world in opioid deaths. But we know from evidence-based surveys that the United States, I guarantee you, has no more pain than any other country in the world. We do not suffer more pain. We do not have more accidents in terms of falls on construction. And yet, our standard doses compared to the 30 highest opioid prescribers, are on average 5 times higher. 5 times higher. It's a dubious distinction, both of them. And the real question is, how did we get here? We lead the world in opioid overdose deaths. And in 2016, the CDC recorded over 60,000 drug-related deaths, of which 40,000 were due to opioids, and of which 20,000 were related to fentanyl. So we have a massive problem with regard to opioids. The scene is shifting away from deaths due to prescription opioids to deaths due to fentanyl. It is so bad now that policemen, firemen, librarians are trained in rescuing people from overdose deaths. Drug-induced deaths in Europe are also increasing. Fentanyl is making its way into Sweden. It's making its way into other parts of Europe. Treatment entry in Sweden, the opioids account for the lion's share of people in treatment. Cannabis is another percentage, and other drugs as well. But the good news for Sweden is that compared to the average of many European countries, Sweden is lower in terms of cigarette smoking, alcohol, heavy episodic drinking, and cannabis. So Sweden has done a reasonable job. But how did the United States get to where it is now? What were the root causes? And how can we reverse engineer some of these root causes? Some of them relate to medical education, generational forgetting, and I will try to explain that in a moment. Quality science. We conduct 85% of the world's research on drugs, and yet people were fooled by a very mediocre little letter to the editor. Pain management and opioid prescribing was not adequately taught, and addiction training was not adequately taught. And we had a giant disconnect between the medical community and the treatment community. So physicians ignored addiction because they said, that's rehabilitation. That's not part of what we should be doing. After all, we have so many things to worry about, infections and ulcers and cancer. This is a separate issue that can be dealt with by others. The generational forgetting is a very simple one. In 1820s, in the New England Journal of Medicine, 200 years ago, we were aware that opioids can be addictive, very addictive, because by that time morphine had been isolated from the opium poppy. We were also aware that opioids can kill people if they're given in overdoses. We were also aware that if we administer opioids for a long time, they may not be as effective. In fact, they may be detrimental. These are some things I copied from these ancient texts 200 years ago of physicians trying to reverse an overdose by developing a tube that goes into the stomach and suck out the opioids, or making people vomit with vinegar, acetic acid, to get rid of the opioids. 1828. We had a vast opioid addiction epidemic in the United States because morphine was the best drug a physician could administer. It was good against diarrhea, against coughs, against pain, against depression. And more women were addicted than men at the time. And then when the Civil War came, soldiers became addicted because the injectable form of morphine became available. So we had an opioid addiction for 200 years. We also had opium dens from people who were imported from China to work on the railroads. What happened? What happened to our country? In 1980, just a few decades ago, there was a 5-sentence letter to the editor of one of the 2 most prestigious medical journals in the United States. The title was, "Addiction is Rare in Patients Treated with Narcotics." And it said that they examined the records of hospitalized patients. There were about 40,000, and 11,000, 12,000 received narcotics, and only a handful showed an addiction. And they concluded that the administration of narcotic drugs to pain patients is not addictive. Now, I showed this 5-sentence letter to Harvard Medical School students in January, and I said, tell me what the flaws are in this letter to the editor. And in 5 minutes, they found all the flaws. So I ask you, what are the flaws? Can you think of them?
Just people who are in treatment, who are in hospital.
Hospital, that's one. Thank you. You've got 4 minutes left. Well, of course, it was hospitalized people in which their narcotics were supervised. And it was very short term, post-surgical pain, acute injuries, broken ankles, legs, accidents. There was no follow-up. They didn't even define what addiction is. The evidence was weak. But, so, was it safe and effective for chronic pain? Were the opioids safe outside the hospital? Did they lead to addiction when given chronically? Were there safer alternatives tried? And so on. None of these questions were asked. But as a result of this letter, 600 other journal articles cited this letter as proof that opioids are safe. 600. That's so unusual. Usually a letter to the editor, 5 sentences, gets 10 citations. This was 600. People wanted to believe. It's almost as if they wanted change for change's sake, a new way of looking at things. And so there was a movement to pain management. They shifted the blame to the provider. Physicians were sued, some cases millions of dollars, if patients were not adequately treated with pain. A patient movement arose. The pharmaceutical industry spent tens of millions of dollars promoting opioids, holding conferences with the American Pain Society. I can go on and list all the associations. They send detailers, salesmen into physicians' offices to push opioids. And then our own government, the Veterans Administration, they designated pain as the 5th vital sign. 3 years after the president of the American Pain Association said it should be a 5th vital sign, with blood pressure, heart rate, breathing rate, and temperature being the 4 vital signs. Now pain was the 5th. And then the Joint Commission that accredits hospitals designated pain as a 5th vital sign. And very soon the pressure was on physicians to start administering drugs that were opioids, that we had a 200-year history knowing they were dangerous. The Open Society Institute, which is promoting and advocating legalization, medicalization of marijuana, published a pamphlet saying that restricting opioids to patients is a reflection of the war on drugs. And they were part of the movement. Pharmaceutical companies are still paying $9 million. 5 manufacturers are paying money to pain associations to this day. And they are moving into Europe, and they're moving into South America, and they're moving globally. So, were we able to reverse engineer past healthcare missteps? These were the pressures on physicians to improve medical education in this area, to improve patient education, to stop the focus on pain. Everybody has pain. How many of you have never had pain? How many of you have craved opioids? Of course not. Why the focus on pain? There were insurance barriers for appropriate treatment for addiction. There was inadequate guidance on prescribing opioids. And our own government, the Centers for Medicaid and Medicare Services, actually discouraged the use of non-opioid treatments for pain because it's so easy to write a prescription. Because physicians were given 13 to 15 minutes to see a patient. If you want to talk about how to manage pain, exercise, back exercise, physiotherapy, non-steroidal anti-inflammatories, there are many alternatives, but that conversation can be half an hour. And how long does it take to write a prescription? A minute or less. There were financial incentives to handle pain with opioids because patient satisfaction scores became very popular. If a hospital showed that they had good satisfaction scores, they got higher reimbursements. And if patients said, my pain is not well treated, then the hospital scores went down. And so on. So we had to reverse engineer these problems. The pain scores in every doctor's office and every hospital, there were pain scores, and physicians began to push pain. Pain medications, opioids, increased by almost 4 times in 15 years. And we currently have 12 million people misusing opioids and at least 3 million people who are addicted to opioids, either heroin, and we all know these are underestimates. And then heroin reemerged. Its purity went up, its price went down, and simultaneously, labs in China, other places in Asia began to produce fentanyl, which compared to an American copper that's this size, those little dots, the crystals, that's a lethal dose of fentanyl. And compared to heroin, carfentanil and fentanyl are about 50 times more potent and more lethal. So we had a perfect storm in the country. When people started to cut down prescription opioids, the street drugs were there to replace them. Now, I must say we talk about prevention, intervention, treatment, recovery support services, all these wonderful goals. And we disdain the supply reduction, we disdain the concept that we have to have a criminal justice system involved in this. In 2006, we had a fentanyl overdose crisis in the United States. Approximately 1,000 people died due to fentanyl, And one super lab in Mexico was responsible. And when that super lab disappeared, which had disappeared overnight, the crisis disappeared, and the overdose deaths due to fentanyl went back to baseline, which were vanishingly low. So the president appointed a commission. There were 6 members of it, 3 governors, the attorney general from Florida, former Congressman Patrick Kennedy, who was the son of Senator Ted Kennedy and the nephew of President Kennedy, and this very short, old, ancient lady standing beside them. These gentlemen, and Pam Bondi, who's not in this photograph, represent 49 million people. They're in charge of 49 million people. They're state governors and attorney generals. And we were given a very short time frame to produce a commission report that would make recommendations to the president. And the commission's tasks were, what is the current federal funding available? What's current treatment? What's current overdose reversal availability? How do we prevent? What's currently available? How effective are educational messages in prevention? What are the federal prevention programs available? And please make recommendations to the president to improve the issue. So the recommendations, and I will confess that we were sworn in on June 16th. By July 7th, I had 253 topics of what the commission should contain, the report, on my computer. And Governor Christie, who was the chair, called me up and he said, "Kid," and when he called me kid, which in the US means a young child, I loved him for life. But on those recommendations, he said, nobody's going to read this report. It's going to go into the dust of an electronic computer server and will never be read with 253 topics. We have to simplify so that we can reduce it into very concrete goals. My first goal was accountability. I wanted metrics, because that is my training. Metrics means how many people will you treat? What will the outcomes be? How many will relapse? How many will stay in treatment? How many will be abstinent? For what period of time? How many people will be rescued? How many people need rescuing and have no availability? How large is your reach for prevention? Is it effective? And accountability was the first recommendation, the first section of the report. And then came prevention and treatment and recovery and research and rescue and who's going to implement it and so on. And for the composition of the report, I looked at every single phase of the cycle of addiction, which includes where do the supplies come from? And what are the risk factors for getting into addiction? And what are the reasons for escalating use? And can we intervene there? And for addiction, opioid use disorder, how do we prevent relapse? How do we rescue people? How do we treat people? Recovery, lifelong abstinence, and impact on children, on families, on health, safety, cause productivity, and people involved in the criminal justice system. All of these were topics. We ended up with 56 recommendations instead of over 200, and we ended up with 130 odd pages instead of probably 500 pages. And we ended up with topics under all of these titles, recommendations in terms of federal funding, prevention, data analytics, and so on, barriers to treatment, barriers to rescue, recovery support services. there was a section, and I was very interested in what Iceland's representative presented, because there was a section on parent roles. We've known for decades that if parents make a strong stand against drugs, use is about 5%. If they don't make a strong stand, if they use themselves, if they feel it's a rite of passage, if they really don't talk about drugs, use rate is about 35%, 7 times higher. We also knew that social media is a place where many young people get their misinformation. And we knew that the old model of this is your brain, fried eggs in the brain, would not work the way it had been anticipated. So we thought there are many ways of using social media currently that are far more sophisticated and targeted and focused to individuals. We also wanted a school-based screening, brief intervention, referral to treatment, so that you could use computerized screening for young people who are less reluctant to answer questions in electronic media than they are face-to-face with people. We asked to expand treatment, and any person who says expand treatment, educate, prevent, these things are meaningless unless you reduce it to practice and understand the reasons for resistance to change. For example, we said, let's mandate that every physician has to take a course in pain management and opioid prescribing in order to get re-registered with the Drug Enforcement Agency, which they have to do every year. And then I found out that 200,000 physicians had taken a course on opioid management, but only 60% had changed practice. What that means is that you can make all these rules, regulations top down, unless you understand how and what at the discrete levels, it is not going to be effective. So we had a whole list of mechanisms of expanding treatment. We knew there are many rural areas. The United States is vast. There are many areas that don't have specialty services, addiction specialists. So we recommended telemedicine be adopted for underserved areas. We recommended that treatment be referred within 24 to 48 hours of rescue and detection. In other words, treatment on demand. We recommended a whole series of things. For the healthcare community, all the factors that went into pressuring physicians to prescribe opioids, we recommended to reverse all those factors, including screening for pain, universal screening, because everyone is going to say, yes, it hurts. My ankle hurts, my back hurts, everyone has pain. And once you begin to focus on pain, people begin to take it more seriously. We recommended prescription drug monitoring programs for physicians to use. And there are many recommendations that I'm not going to get into. I wish I had my own computer here because there's a lot of animations you're missing. But we recommended to increase quality of treatment. There are 14,000 treatment centers in the United States. If I personally would certify them, I would certify about a third or less, for a number of reasons, because 2/3 do not adhere to principles of evidence-based treatment. The goals, I've looked at Swedish drug control strategy goals, and I'm not going to perseverate on these. We recommended expansion of Good Samaritan laws, of filling the Narcan, or naloxone, which is used to rescue people. And all of these are broad brushstrokes. Reducing to practice means A, B, C, D, E, F, and if this doesn't work, what can we do? If this doesn't work, what can we do? These broad brushstrokes are meaningless without an understanding of how you reduce to practice and how you surmount resistance to change. We recommended big data analytics. Many companies in the United States have vast capabilities of monitoring things in real time, including deaths, what the cause of death is, including gaps in naloxone availability, including how many people show up for treatment and there's no treatment capacity. And we recommended that we fill all these gaps with real-time data in so many ways. We recommended patient education. This is a slide I've shown to so many people without the red flag. And I say, how many of you know that any one of these you may have been prescribed and it can kill you or addict you? Even cough medicine, which has dextromethorphan in it. And most people don't know. They're unaware that they're being prescribed opioids. We recommended important factors with regard to pain experience, knowing that part of pain has an emotional, a cognitive component that is very critical, and yet people don't realize that some people have pain that is psychological, that it's emotional pain, that it's exaggerated in people with psychological problems, people with depression or under stress. We recommended a vast array of consequences and looked at the risks for opioid use disorder in terms of not only the risk factors for individuals, and they're very well outlined, but also how people become addicted, and to try to understand and educate physicians on the pathways to addiction. Inadequate pain control. People who, on first exposure to opioids, feel a tremendous sense of well-being, and they have relief from emotional stress, or some of them that initiate for the psychoactive properties and not for pain management. We recommended a vast amount of research to identify alternatives to opioids, improved medications, improved rescue drugs, medical devices. Imagine 75% of people in New Hampshire, the small state in the New England states, die alone of opioids. So if they can wear a ring that detects that their oxygen levels are dropping, and if they can wear a device that can auto-inject a rescue drug or call someone immediately once oxygen levels. These were the kind of devices. Alleviate stigma, which is so critical. And then it was over. We issued our report. One of many that have been generated, but this one was the first that was targeted specifically to recommendations. And what we feel is that we can solve the problem with wisdom, resolve, leadership, and support. And I'd just like to end. The world is awash with media on the death of Prince, the death of Elvis Presley, the death of Anna Nicole Smith, the death of Marilyn Monroe, the death of comedians, and so many others, Michael Jackson, due to drugs, primarily opioids. But Alas for those who never sing but die with all the music in them. Hundreds of thousands of people have died. Weep for the voiceless who have known the cross without the crown of media glory. Thank you.
Thank you, Bertha. Thank you. Thank you for your tremendous effort in explaining this to us. I think we could have you here for 2 days full and only listen to you, I believe. But I will ask you for a bit of patience, because we have invited medical doctor Kerstin Kjell in psychiatry and addiction medicine to say a few words as well. No, you may not sit. You have to stay here.
Thank you so much for the speech. My name is Kerstin Kjell, and I'm, as was said, a psychiatrist and working in addiction medicine. But I was also a friend and colleague of Professor Nils Bejerot. And some of you may not know who he was, but if he hadn't died prematurely in 1988, he would have been 97 years old now. And he would be proud that the World Forum Against Drugs are making this biannual award. And he would have been especially proud of the recipient this year, which is Professor BERTHA MADRAS. Well, I'm going to steal a few minutes from your lunch by telling you a little bit about the background and about Nils Bejerot. After World War II, Sweden was hit by a massive new epidemic of intravenous amphetamine and heroin use. And that was before it happened in any other European country. And Nils Bejerot was working as a doctor in social medicine for the Stockholm police and for the city of Stockholm. And he cared for many of these addicts. And he was the first person to analyze this new type of addiction, which was quite different from the types of iatrogenic addictions. You know what iatrogenic is? That's what it's caused from medical. It was a prescribed drug that you get addicted to. Because this new type of drug addiction was epidemic and often involved people who were involved in the criminal justice system. For more than a decade, based on his first-hand experience, he fought against the then prevailing policy of permissiveness which we had in those days in Sweden, and which we now would call harm reduction. And in this approach, physicians gave drugs, amphetamines and opiates to the addicts in the hope that they would wean them off the drugs and keeping them from the illegal drug dealers. He saw that this approach not only did not get them off the drugs, but that it spread the addictions, as the addicts sold much of their prescribed drugs. Bejerot saw that drug abuse must be addressed at all levels, including the street level, and that it's necessary to get and keep the addicts from using drugs. In the 1970s in Sweden, this developed into a popular movement under the leadership of Nils Bejerot. And at the end of that decade, based on the success of this drug-free approach in Sweden, Sweden adopted the distinctive, restrictive, drug-free policy that we still have, even as we today have to continue to fight to keep it intact. Okay, and now I will present the motivation for giving this award to BERTHA MADRAS. In all the world, there's only one BERTHA MADRAS. A scientist, policymaker, and leading in the efforts to turn back the global drug epidemic with strength, compassion, and the highest biomedical science. She is a noble heir to the visionary founder of the unique Swedish drug policy, Nils Bejerot. Dr. Madras, like Dr. Bejerot before her, is dedicated to the drug-free vision of both prevention and treatment. She roots her policy recommendations on the recognition of the dehumanizing and tenacious impact of drug abuse on the vulnerable human brain, the chemical hijacking of the brains of addicted people. She supports prevention programs for youth that promote abstinence from the use of addictive drugs, and she supports addiction treatments that produce long-term recovery, which includes abstinence from the use of alcohol, marijuana, and other addictive drugs. For Professor Madras, the goal of drug policy is brain protection. She is professor of psychobiology in the Department of Psychiatry at Harvard Medical School and psychobiologist in the Division of Alcohol and Drug Abuse at McLean Hospital. She served in public office as Deputy Director for Demand Reduction in the White House Office of National Drug Control Policy, a presidential appointment confirmed unanimously by the US Senate. Dr. Madras is a drug policy advisor, continuous innovator, and inspirer-in-chief. She is a world drug policy leader, having served as a contributor to the World Federation Against Drugs for over a decade. In 2016, she served as a panelist at the Vatican Pontifical Academy of Sciences, and in 2017 was appointed as one of 6 members of the Presidential Commission on Combating Drug Addiction and the Opioid Crisis. A graduate of McGill University, Dr. Madras earned her PhD in tryptophan and hallucinogen pharmacology and Bachelor of Science degree in biochemistry, and completed postdoctoral fellowship at Tufts University and Massachusetts Institute of Technology. So, Bertha Madras.
Just, I wonder if I can just say thank you, first of all, to my husband. Can he stand up, Peter? There he is. This is his first trip to Sweden, and I've been to Sweden now 9 times. I'd like to thank Dr. Bob DuPont, who is one of the great and most distinguished mentors, scientists, and policy advocates in our country. Bob, can you stand up? I'd like to thank Sven Olsen, who has been a warrior, and in this case I use it very positively, on the front lines of this. In 1995, I went to Sundsvall in Sweden for the first time to talk about drugs. And it was a memorable moment, which some of you should discuss with me, because one person stood up and said, anyone who advocates what you've said is a criminal, you are a criminal, and you should be put in jail. And because I was talking about medications to help certain people get rid of addiction. And I looked at him, and instead of having umbrage, I said, let the science talk. If the science says that people stay in treatment, that they reduce HIV/AIDS, that they are abstinent longer, that they're not involved in the criminal justice system, that they have jobs, they return to their families and to social life. If the science says that, how can we argue philosophically? And a few years later, he asked me to help with introducing medications. So,
well, this is the award. Thank you. And this is a small chart with the motivation.
Okay. Well, thank you, Kerstin, for delivering that message. And thank you, Bertha, for being you.
Thank you.